Big welcome to all of you. I think we will still have some people joining, and I am very excited about today's session, our regular G-Echo, Gastro-Echo patient blood management slot. And I want to start by just acknowledging and thanking the Gastro Foundation and the G-Echo program for making this possible. We've got about 111 people registered for this session from 10 different countries. We've got people from Cameroon, Ireland, Kenya, Mozambique, Nigeria, Namibia, Sudan, Switzerland, Zambia, and Zimbabwe. And I don't even see South Africa there. So South Africa obviously is well represented as well. So a great welcome to everybody from all these different countries. And I want to encourage you to put your questions in the chat room at the end of the talk. We will open it then. And I also want to give a special thanks to Professor Axel Hoffman, who is joining us today. Prof. Hoffman is a doctor of medical science. He holds a master's degree in economics. His main activities are related to patient blood management research and implementing PBM programs around the world. He's been super active, helping Australia, China, Brazil, South Africa, and many other countries get off the ground. He's an old friend and a regular visitor to South Africa, and we're very excited to have him on this platform, I think for the first time on this platform today. And he promises to give us some new information that I'm personally looking forward to. So thank you, Axel, for coming. We really appreciate it. I also am very happy to see a lot of old friends in the group here. I see Anna Metsakaza and Elmira Leshah and Dr. Roy Sparmer and some people that we've worked with, and we're happy that you could join us. I want to also thank the Echo University New Mexico and Echo India teams for providing technical support today. There will be a feedback form in the chat that you can just give your feedback on if there's any issues that you encounter or any compliments you want to give. Recordings of the session will be available on the Gastro Foundation website afterwards. And I also just want to, for all those of you who are interested, there will be a session on gastroenterological pathology with Drs. Martin Hale and Bilal Bobat from Wits University at the next session. So without further ado, I'm going to hand over to Prof. Hoffman and to share with us what has really become a revolutionary thing in the field of healthcare, and in my opinion, probably one of the most impactful things in medical science, which is quite unusual in that it saves cost while improving patient outcomes. So, Axel, thank you very much. Thanks for making the time. Over to you.
Thank you, Vernon. Good afternoon, everybody. Thank you for the organizers to invite me, especially the Gastro Foundation and G-Echo. So you can see from the slide, my topic is patient blood management, a solution to many problems for Sub-Saharan Africa, ? My affiliation, as you can see, with the University of Western Australia, the University Hospital in Zurich, the International Foundation for Patient Blood Management, and the Society for the Advancement of Blood Management. So let's see. Are the slides moving?
Yes, perfect.
So here's my disclaimer, starting with governmental and public institutions, blood services, professional societies, and NGOs and industry. The definition of patient blood management, an evidence-based bundle of care to optimize patient outcomes. How? By managing and preserving a patient's blood. And to lead you into this topic, I'd like to start with the challenge, with the problem of the 3 independent risk factors for adverse outcomes. And the first one is anemia. According to the Global Burden of Disease study, the impairment affecting the greatest number of individuals on planet Earth is anemia, with 2.4 billion individuals, of which 1.4 billion, 1.5 billion are iron deficiency anemic. And taking some data from the work of Nick Kassebaum in blood, anemia prevalence in selected countries, you can see that even in high-income countries like France, Belgium, Germany, the prevalence of anemia in the general population is around 12% for females from 15 years and older, and also males from 60 years plus and females 60 years plus. But you can see South Africa sticks out with an anemia prevalence, except the males between 50 and 59, of around 30%. If you look at the BRICS countries, then South Africa has a higher anemia prevalence. However, the leading country is then India. But then if you pull up the data from Sub-Saharan Africa, Central, East, and West is having clearly higher anemia prevalences than the southern part of Sub-Saharan Africa. Now, there is a misconception that says the prevalence of anemia in surgical patients is similar to the general population. However, this is not the correct view. In patients undergoing major surgery, the prevalence of preoperative anemia can reach up to 75%. And here's a overview of different studies looking at pre-op anemia across common groups of surgeries, and looking at the audience today, which is primarily people from or clinicians around the field of gastroenterology, probably oncological surgery. You see in abdominal surgery, these studies show prevalences of up to 52%. I also found some data from South Africa. Here we see in anemia in patients undergoing open intra-abdominal surgery, an anemia prevalence of 71%. And again, 71% of the 71% are having severe or moderate anemia. And the overall prevalence of anemia was associated with a threefold higher risk of post-op mortality, and that was more pronounced in patients with moderate and severe anemia than those without anemia. There's also data from Ghana showing the prevalence in females between 15 years to 49 and more than 50 years. It's between 61 and 66%. And again, you can see that the rate of moderate and severe cases is twice as high as the rate of mild cases, which is a very different pattern compared to Western European or North American countries. In the same study from Ghana, you see that the after adjusting for confounders, the odds ratio for prolonged lengths of hospital stay with the anemic patients is twice as high. And if we add transfusion to the picture, is 4.5 times as high. There's also data from the South African Surgical Outcome Study published in the South African Medical Journal with an anemia prevalence of 48% in 3,610 individuals. And here again, for our audience, patients with upper and lower GIT and hepatobiliary surgery have a prevalence of 45%. This is from 623 individuals. And you can see that the in-hospital mortality in patients with and without anemia, the odds ratio for the anemic patients is 2.7 times higher, and particularly for those with severe and moderate anemia. And it's also an independent predictor for critical care admission, about 1.5 times higher. Coming back to a very large database, the NESCIP from the United States, looking at 230,000 patients, of which 70,000 were anemic, the researchers looked at the impact of pre-op anemia and post-op outcomes across all non-cardiac surgery in terms of 30-day mortality and composite morbidity. And you can see on the x-axis down here, from borderline anemia with 38% hematocrit down to about 20%, you see that both mortality and composite morbidity are increasing in a linear fashion. If you then look into the appendix material, you will find that even mild and moderate anemia increases the odds for mortality and morbidity by 40 or 30%. And when you add transfusion to the picture, it does not improve. In fact, with the transfusion, mortality is then twice as high and morbidity about 80% higher. So one of the early take-home messages, anemia is bad, however, transfusion doesn't improve it necessarily. I think the probably largest study to date is that from Fowler, looking at 950,000 patients from 24 studies, of which 39% of the population were anemic. And the same picture, anemia was associated with an almost threefold increase in perioperative mortality, almost fourfold in acute kidney injury, twice as many hospital-acquired infections, and in the subpopulation of cardiac surgery patients, a 28% increase in stroke. And what is also notable is that transfusion is driven by anemia with an odds of 5 times as much compared to the non-anemic patient. So here's from your aforementioned paper, another misconception. I think we have cleaned up that one. Preoperative anemia poses no risk to patients, and scheduled procedures should not be delayed because of its presence. The key point is no, preoperative anemia is independently associated with worse clinical outcome, and whenever feasible, should be corrected before the scheduled procedure. Now, this leads us to the second independent risk factor for adverse outcomes, which is bleeding and blood loss. And we all, I think, agree it's a no-brainer that mortality, morbidity, hospital lengths of stay, and ICU lengths of stay, and transfusion is, of course, driven by acute blood loss and bleeding, whereas the main culprit is surgical interruption of vessel interruption, and only for the remainder it's acquired or congenital coagulopathy. Now, for 70, 80 years, the default position was when facing anemia and or blood loss is transfusion. However, there is accumulating evidence over the last 2 decades that transfusion per se is also an independent risk factor for adverse outcomes. And having in mind that my audience today is from the field of gastroenterology, I'm looking more into studies and meta-analyses and reviews that deal with your patient populations. Here is the effects of allogeneic red cell transfusion on the outcomes with patients undergoing colorectal cancer surgery. 21,000 patients, of which 59% were transfused. And you can see that all-cause mortality, cancer-related mortality, recurrence, metastases, and death are increased by about 70%, while infection is 3.3 times as high compared to the non-transfused, and the length of hospital stay is about 4 days longer, all statistically significant, as you can see. Or here, in the same population of a group of patients, 36 studies with 174,000 colorectal cancer surgery patients. And you can see that with transfusion, the hazard ratio for overall survival and disease and cancer-specific survival drops by about 2/3. The disease-free survival is non-significant. And at the same time, post-op infectious complications, pulmonary complications, cardiac, anastomotic, reoperation, and general complications are increasing with risk ratios somewhere between 1.5 and 2.9. And therefore, the authors conclude Perioperative transfusion causes a dramatically negative effect on long-term prognosis and increases short-term complications after colorectal cancer surgery. Another study that was just recently published with 184,000 patients and 123 studies. And I have to say that 119 of these studies are for gastrointestinal patients and mainly. And they also start by saying allogeneic red cell transfusion exert a potential detrimental effect on the survival when delivered to cancer patients undergoing surgery with curative intent. And you see red cell transfusions are associated with an increased risk of death, hazard ratio 1.5, relapse hazard ratio 1.36, and even survival was even reduced in cancer patients at early stages with a hazard ratio of 1.45. This study looks again in non-cardiac surgery with 125,000 patients, and they were focusing just on 1 or 2 units of red cells administered intraoperatively. And you can see a dose-dependent effect from 0 transfusions to more than 10 in terms of mortality and morbidity. And you can see that pattern repeatedly. Every study, and here are studies from the last 20 years, reporting dose response increase in adverse outcomes associated with red cell transfusion. Some of the studies include almost 1 million patients, like the one from Vic Ferraris. And you will not find any study that looks at dose dependency that would not see this pattern. So the more transfusion, the more of adverse outcomes. And then there's probably something of special interest, the likelihood of blood transfusions being associated with thrombosis, especially VTE and ATE. You can see from 500,000 hospitalizations in cancer patients in 60 US medical centers that for VTE and ATE, the odds are up by 50 to 60%, and also in-hospital mortality by 34%. And I thought I'd give you a little, it's probably not pure science, but it's a little impression that's quite interesting and thought stimulating. This is a picture of a patient who bled down to 2.8 grams hemoglobin due to a GI hemorrhage. And with a high density light and a microscope, a cytoscan, you can see that despite, of course, he is he has a good fluid management and he is urinating, he's awake, he is tachycardic, but perfusion is relatively good. And now the patient gets a 3-unit transfusion, and you can see a total change in the microcirculation, both in the multi-cell and the single-cell capillaries. So people might say, well, this was all observational data, but don't we have level 1 evidence for the efficacy of red cell transfusions? Again, before we answer this question, we would like to focus that the question on restrictive versus liberal transfusion trials, these are the ones who you might think look at the efficacy. We said here in this article last year, are they asking the right question? In fact, all these trials, liberal versus restrictive, they are not testing the efficacy of transfusion. What they do, they compare less with more transfusions. But a real efficacy test would be RBCs versus placebo or RBCs versus another intervention. What they do, they test anemia tolerance at different levels with subsequent transfusion. In other words, to what extent lowering the hemoglobin threshold for transfusion can be tolerated safely. And you're all, I guess, familiar with the Villanueva study on upper GI bleeding that had the restrictive group with the NADI hemoglobin of about 7.3 versus the liberal with 8, you can see a discharge. It was 9.2 versus 10, and there was no difference after 45 days. However, quite interesting is the huge difference in the units being transfused, 670 versus 1638. And in terms of the outcomes, you see that the restrictive group has a significantly better survival, plus the restrictive group has significantly less further bleeding and significantly less hospital stay days and less adverse events, of which most of the ones sticking out is less transfusion reactions, less TACO, and less cardiac complications. And there's also one very interesting meta-analysis and systematic review of the more than 60 that are available. This one is the one with the largest delta between restrictive and liberal, less than 70 versus more than 90. And you can see that the restrictive group does significantly better in terms of mortality and complications. And because we are now talking to an African audience, I think this is a very interesting study that kind of shook the foundations in terms of what is really the right hemoglobin or the right threshold. It was a randomized controlled trial in about 1,600 children with uncomplicated severe anemia with a hemoglobin of less than 6 grams, and they were randomized to the group with immediate transfusion upon hospital admission, and the group that either got transfused with new signs of severity or a hemoglobin of less than 40 grams per liter. And interestingly, there was no significant difference in mortality and clinical outcomes in both groups. However, transfusion was performed to 100% in the group with less than 6, but only 49% in the group with less than 4. So coming to a conclusion with transfusion, we see a dose increase of transfusion and across many adverse outcomes. We now look at least 6.1 million patients in about 60 large observational studies that demonstrated dose response increase of adverse outcomes with transfusion. But we also have a large number, as I mentioned, of systematic reviews and meta-analyses of RCTs with with restrictive versus liberal. And in all of those, we see either no difference or we see that the restrictive group does better in terms of mortality and in terms of infection. What is very sobering is another observation which has to do more with behavior rather than with the patients. Here's work from Jens Meyer, who looked at transfusion thresholds and the actual practice of transfusion triggers. That is the AABB suggestion for patients with pre-existing cardiovascular disease, and here's 7 grams without. However, this is the reality, and this was undertaken, mostly not indicated, risk for patients, cost for the healthcare system. And this is recent work in 126 centers in Europe, a snapshot over a week with 5,800 patients, of which have received at least 1 unit of red cells. So looking at this whole spectrum of challenges shows us that blood loss, anemia, and transfusion are really a triad of independent risk factors. And now we would like to go from the challenge, from the problem to the solution, and explain to you how patient blood management works. In fact, we've got a more precise idea in 2005 when we conducted this study of blood use in elective surgery, the Austrian benchmark study, where we're able to predict 97.4% of all elective transfusions by the level of anemia prior to surgery, the volume of blood loss, and the transfusion trigger. And you see uncorrected anemia, insufficiently managed blood loss, and liberal transfusion is something that is modifiable. And this is how PBM works. We modify these factors. From uncorrected anemia, we go to corrected. We optimize the red cell mass by stimulating erythropoiesis. Permissive blood loss and bleeding is replaced by minimization of blood loss and bleeding and the liberal transfusion behavior by harnessing and optimizing the reserves that humans physiologically have. And you can go into further detail, but we don't have time for this. I just want to focus on this point here. Detect anemia is the first thing, correct the anemia and the underlying disorder, and you have won big time. What are the outcomes? Here is some work from Bernd Frössler in Western Australia. Again, you're close to your patient population, major abdominal surgery, 72 patients, anemic. The one got anemic or iron deficiency anemia, got carboxymaltose. The other group was treated with transfusion. However, the study had to be terminated after a few weeks before, after a few months, because the ethics board saw that the intervention group did so much better that there was no reason to continue. You can see in the pre-op iron group, transfusions dropped by 75%. The initial hemoglobin increase to surgery was almost a gram compared to the transfusion group. The hemoglobin after 4 weeks was significantly better in the intervention group, and the hospital length of stay was about 1/3 less. Another interesting study was done in Zurich with 253 anemic, iron deficient, anemic patients and 252 with isolated iron deficiency, and they were randomized to either placebo or combination treatment of FCM, erythropoietin, vitamin B12, and folic acid on the day before surgery. In other words, patients where we did not have the time to correct due to urgency or emergency. And the primary outcome was the number of transfusions during the first 7 days. And we could see that the placebo group had a median of 1 unit, whereas the intervention group had a median of 0 units. Remarkably, the hemoglobin, the retic count, and the hemoglobin in the retics were increased significantly on post-op day 1, 3, and 5. So we have a nice proof of principle. It's never too late to start with the anemia correction. At this point, a very brief excursion, people might say, well, wasn't it a few weeks ago that we had this major abdominal surgery management of anemia study, PREVENT study, a randomized double-blind controlled trial? Yes, we had it. We see here the red line is the IV iron group, and here's the placebo group. And we can see that the IV iron group has all the way a high hemoglobin. However, these investigators interpreted pre-op intravenous iron was not superior to placebo to reduce the need for blood transfusion when administered to patients with anemia 10 to 42 days before elective major abdominal surgery. However, that study has got profound criticism. We don't have the time to go through it, but in short, it's a very poor study design because they chose transfusion reduction as a primary endpoint, but in the absence of a transfusion algorithm. They did not define iron deficiency as an inclusion criterion. Therefore, patients with non-iron deficiency anemia were included, although monotherapy with IV iron in these patients is contraindicated. Furthermore, they didn't report on the breakdown of RBCs, FFPs, platelets, nor did they report on inflammation markers, intraoperative blood loss, and coagulation parameters. And at the end, because of an insufficient time frame for pre-op anemia correction, only 21% in the IV iron group had their anemia corrected. However, there were some, from those criticizing, some positive remarks. For instance, that the number to treat was 11 for the administration of iron. to prevent one unplanned hospital admission. And I think in terms of cost effectiveness, this is a very interesting angle to look at. And here you see that monotherapy with IV iron works on IDA and FID. However, it doesn't work alone on anemia of inflammation or intravenous non-iron deficiency anemia. I think this is also very important in the African context. I found this paper on anemia, micronutrient deficiency, and malaria in children and women in Sierra Leone. And you see these groups here are the anemic groups. Only the light pink are those with isolated anemia. The others had either anemia and malaria or anemia and inflammation or all three. And of course, here we need another treatment regimen. So back to patient blood management, here is probably the world's most important study, the world's largest, with 605,000 patients over 6 years, run by the government of Western Australia. What they did is an inclusion of all emergency and elective medical and surgical patients, and we looked in the study at the outcomes at the 4 largest hospitals in that state. We saw in this highly modern healthcare system a reduction over the study period of 28% in in-hospital mortality, 15% less hospital lengths of stay, infection, IMI, myocardial infarction, stroke went down by 21 or 31%, a slight readmission from a small baseline. The low baseline was by 6%. The readmission rate, sorry. We had a very low proportion of patients admitted anemically. In fact, we can say, eradicated anemia in the elective setting because we fix it before the intervention. The remainder is just for urgent and emergent cases. At the same time, we reduced blood utilization in the state by 41%, adhered to a very restrictive threshold, and we were able to save the system at least $80 million in transfusion-related costs. So PBM really reduces mortality and morbidity while it's saving costs. Therefore, we would say PBM is state-of-the-art, and it's important to know that the World Health Organization endorsed it already with a resolution in 2010. And currently, the action framework to advance universal access to safe, effective, and quality-assured blood products has a wonderful definition, exactly the one I read to you, almost the same at the beginning. PBM, an evidence-based practice to optimize medical and surgical patient outcomes through the preservation of the patient's own blood. Their plan is the effective implementation in the coming years, and based on national clinical guidelines and practice standards, and with a quality system in place. And you can see there are already many places around the globe where they have these instruments. We also have them by specialties, including cancer-induced anemia, chemo-induced anemia, and cardiac surgery and other fields. And the final question is it also a solution to the many problems in Sub-Saharan Africa? Yes, I think it is. There is an article that is titled exactly that way in the South African Medical Journal. It's also supported by authors who are in key positions with the blood services of the country. It also made it to the news. And the article says, first, the population is suffering from many forms of anemia, IDA, HIV-related, inflammation-related, malaria-related, from intestinal parasite infestations, and of course in hospitalized patients. And the implementation of PBM would represent a major opportunity to sustainably improve public health in that country in terms of child mortality, maternal mortality, anemia and blood loss-related adverse outcomes, transfusion-related adverse outcomes, and overall surgical and medical outcomes in hospitalized patients. And just coming back to that one very neuralgic area, the findings of a study on maternal mortality in more than 300,000 women, the odds ratio would anemia is just, for mortality, is 2.36 times higher. And therefore, the prevention and treatment of anemia during pregnancy and postpartum should remain a global public health and research priority. I know it's not about gastroenterology patients, but I think it's a huge public health issue, and therefore I mention it here. Second, says the paper, the implementation would ease the pressure on the nation's blood supply, and the demand for blood is expected to increase unless we don't have a really big practice change. And I found it strange in this Lancet Hematology article on the global need for blood products. They spoke of about 304 million units that are needed, plasma platelets and red cells, and 272 million were supplied. They talk about strategies for blood availability in low-income and middle-income countries, but they don't mention patient blood management. It's a pure product focus. And if you look into that document, blood demand, the question that needs to be asked, why pushing the global supply above 300 million blood components? Rather than asking, why not reducing the demand by 50% or 150 million components simply through the application of PBM? This is truly a patient focus, moves away from the decade-old product focus. And if we look at your region, Sub-Saharan, and if you look at digestive diseases, you see it's a big chunk that comes from you patients that drives the demand for these products. And so the article concludes with the third dimension, the overall economic argument that unmanaged and poorly managed anemia also impairs the cognitive development of children and adolescents, with losses up to 9% of the gross domestic product. These are data from Bangladesh. And furthermore, PBM is, as we said, associated with better outcome and less cost. And here, this slide shows us from Zimbabwe that just 1 unit of red cells is equal to 13.7% of the country's annual gross domestic product per capita. I think that speaks for itself. Therefore, the decision to allocate more resources to supporting the product-focused transfusion model rather than the patient-centric model could be likened to the establishment of landlines in a geographical area bare of communication infrastructure, rather than setting up highly effective and much less costly mobile phone networks de novo. So here are the few take-home messages. We showed you the triad, which poses a safety problem, a quality problem. It's all missed opportunities, ignorance to guidelines, disrespect towards the donor. It's a cultural big problem, and this has to stop. How long can one go before administering a transfusion is the wrong question to start with for a clinician. Why are red cells administered? People say, well, the HB level dropped to a critical hematocrit. However, we saw the debate on this is going on anyway, but the real clinical question should be, why is this patient anemic? Why is there a surgical blood loss, a iatrogenic blood loss, a disease-related blood loss, coagulopathy? Why did we miss out on multiple opportunities to preempt early on that we would reach the critical hematocrit? This is the paradigm shift. And also the behavior-based transfusion practice that is mostly not driven by evidence, but by ignorance, by negligence, and sometimes simply by fear. So the right question is, what can be done to minimize or eliminate the causes of anemia and blood loss? And this is definitely with PBM. What started in Australia and some other places in Europe has meanwhile big repercussions, and it is becoming the new standard of care, and hopefully you, those who have listened today, are becoming part of this big improvement. Thank you so much.
Axel, thank you so much for a fantastic talk and such a nice, succinct overview of what patient blood management is. I think the chat box should be open now. So you are welcome to either ask a question in the chat box or just unmute your microphone introduce yourself and speak up. So can I hear if there are any questions? Axel, maybe I will just open the floor with a question that some people may raise, just because I think this is a common question that both of us are asked from time to time, and I think useful to discuss. So some people would say, well, the reason why patients getting transfusion have a worse outcome is because they are sicker in the first place. How would you respond to that?
Yeah, I mean, first of all, this is why we do in every of these analyses a multivariate regression analysis, right? And also we do propensity score matched analyses in order to rule out that there are other factors. And of course, we are not saying that transfusion is obsolete in all cases. However, what we are looking at is this big chunk of, let's say, 2 to 3 unit transfusions, where all the other opportunities that in one of my last slides I described as missed opportunities are not being used or not being exploited. And then we end up with a transfusion that was clearly avoidable in the first place. And I think here we have data that are crystal clear when we see a reduction of transfusion in, like in Western Australia, where we had already one of the lowest transfusion rates in the Western world, have decreased by another 41%, and see at the same time a highly significant decrease of mortality and morbidity rates, then I think we have a great answer from real world data.
Great, thank you so much. We've got a question here for you, Axel. Who should be the main actors to implement patient blood management?
This is an excellent question. And everyone who listened in today. But what we see is, what would be ideal is a top-down and bottom-up approach in parallel. I think N=1 is what the clinician sees. And I think every clinician who wants to do good medicine, I think it was your colleague and our friend Anthony Beaton said, PBM was invented by physicians who wanted to be better doctors. So this is really where each one has to start. At the same time, we need some adjustments in the infrastructures of the hospital systems. And this is where we need to have the governments coming in. This is where we are grateful for the World Health Organization that they took on this task and says, let's have quality systems in place. And I'm sure the World Health Organization has started to communicate to the world's governments, and especially to the departments of health and the ministries of health, to really help to create the right infrastructure, that we have a system in place that can preoperatively screen for the anemia, especially also in the area of obstetrics, by the way. So important, you know, not acting when most of the bonus is gone, but early on. That we have, like in an example where the government stepped in, even with legislation, which might not be the best solution. However, it's interesting. In Italy, they have a decree in force for the last 3 years, where they basically say a patient in the elective setting that is anemic cannot be operated on. First, the anemia has to be fixed, and then he can come back to the hospital. So another point would be the reimbursement. You know, we have this huge focus for decades on establishing Western-style blood banks, which, I mean, having safe blood is of course important. But looking at the cost effectiveness, it's probably more important to spend an equal amount of money in pre-op anemia management and coagulation management and the things I just presented.
If you would give advice to gastroenterologists on where they should start, What are the low-hanging fruits for them?
Well, I'm not too familiar with the challenges of that discipline. However, at least when I look into their surgical patients, right? We had a lot of evidence today on patients with gastric cancer, colorectal cancer. That's where we have most of the data, at least. And we've seen how many of them are anemic, right? So I think we should, the anemia screening, the iron status, I think should be a standard in the diagnostic pathway for the future so that we can preempt the anemic part. And then, of course, you have all these, they know it better than I do, but the clipping, the coiling, the lasering, the electrocautery, um, the all the possibilities to stop the bleeding. I look quickly into the up-to-date on how to manage bleeding in gastro patients, and interestingly, they start with the transfusion, and then in the second or third chapter they talk about stop the bleeding. I mean, all the PBM people, guided by Arye Shender in the first place, said stop the bleeding first, and then think about replenishing what has been lost.
Wonderful. Axel, thank you so much. And I just want to reiterate this whole issue of anemia tolerance. So I always say, and this is something gastroenterologists may well encounter, if a patient walks into your office with a hemoglobin of 2, the most dangerous thing you can do is to give them blood. Sounds strange, hey? But this is how patients actually die from blood transfusion, because if they walk in, they are compensated, they've expanded their plasma volume. And if you want to give them blood, you should actually give them an exchange transfusion. But in our experience, a patient that walks in with an HP of 1.9 to 2.1, which we see quite commonly, from a B12 or an iron deficiency, you just put that patient in a bed, give them iron, give them B12, folate if needed, and wait. That HP, that bone marrow is so ready to respond. You will not need a transfusion. And unfortunately, it happens very often. And in my department or division of clinical hematology, that patient does not get blood if they walked in. As a matter of fact, I consider it as a serious breach of our protocols if that happens. It's only the patient who's got some medical emergency, who's hemodynamically unstable, who's bleeding out, where you have to jump. But in that compensated patient, it tells you how much patients can tolerate. So another example, in our transplant unit, we look at the patients clinically. We don't want them to have the negative effects of transfusion. Many young people are fine with an HP of 5.4, 5.5, and we don't transfuse. We've actually done transplants without transfusion. So I think that's just something to know. And then as a challenge to the surgeons out there, taking the anesthetists, taking the flag from the Swiss people who were doing liver transplants without transfusion, the team at Groote Schuur, and I think other teams in the country now as well, have taken up the challenge and are now doing many liver transplants without blood transfusion, using the principles of patient blood management. Yeah. I've got a brief case that sounds like a briefcase. I've got a short case that I want to quickly share, just to give you some food for thought. And let me just find the right screen. Okay, let's go. Let's look at this. And I'm just going to share a quick case to explain the principles or to apply some of the things that Axel has mentioned today. So we've got a 49-year-old female patient who needs a gastrectomy for a type 3 gastric carcinoid that affects the proximal stomach. She's tired, she's got craving for ice, and she uses non-steroidal anti-inflammatories and omega-3 fish oils for joint pain. She's on St. John's wort for depression. She's pale, but otherwise no other clinical findings. Her hemoglobin is 9.5. She's got a ferritin of 95 and a transferrin saturation of 15%. The surgeon wasn't initially concerned about the hemoglobin because, you know, he thought blood is safe, which it typically would be in terms of infectious risk and HIV transmission and so forth. And the blood service supposedly always have enough stock of red blood cells. So he plans to admit the patient the day before surgery and, if needed, transfuse a unit or two of blood. And then if there's significant bleeding, to give more transfusion. Now, if we lived in a perfect world, if we all lived in La La Land, a patient would come to surgery with a pre-op hemoglobin that is normal because the surgeon had optimized it. Intraoperatively, no blood would be lost or all blood would be salvaged, thanks to all these wonderful things that we've heard. And post-operatively, the same thing would happen. But in the real world, we've seen that in South Africa, for instance, 47.8% of patients have a suboptimal preoperative hemoglobin. It decreases further during surgery, and post-op, it is even worse. And the traditional paradigm that I also grew up with and that I had to relinquish is a traditional one of just transfuse, transfuse, transfuse. And that's why surgeons use about half of the world's blood supply. So Axel already alluded to this article that was written in Anesthesia and Analgesia, showing the essential role of patient blood management in a pandemic, a call for action. And they, as part of that article, we presented a toolbox, an ABC toolbox. I'm not going to share the whole lot with you, that can be used, that if you have a patient like this 49-year-old lady who comes anemic, you can apply this patient blood management toolbox and optimize her hemoglobin beforehand. And we do that, of course, by diagnosing the anemia and then finding the cause. Remember that anemia is never the final cause. You must look for whatever is underlying. Iron deficiency is one of the causes, but still not the final cause. You need to know why the patient is iron deficient. In this case, it's that gastric carcinoid. So in this patient, if this patient had a ferritin less than 30, it would have been easy. You could have said straight away she's got iron deficiency anemia and treat. But now she falls into this difficult category with a ferritin of 95. And that's where the transferrin saturation helps you. Because this means that because of the underlying malignancy, she's got a ferritin that is slightly raised due to an acute phase reaction. But you can still diagnose the concomitant iron deficiency using a transferrin saturation. So this patient needs treatment. How do we optimize timing? Treatment, you must think time. Look at the date of surgery. Ideally, 6 weeks before you want to treat the patient. And of course, the lower the HB, the more time you have. So especially if it's elective surgery, you must have time. Sometimes you don't, but Axel has shown that even if it's 1 day before surgery, the patient will still benefit from treatment. So in a simple iron deficiency, in a pre-op patient, you can give oral iron. Ferrous sulfate is cheap but poorly tolerated. There are many other better irons now that are well tolerated. Importantly, we now give it either once daily max, or you give a double dose Monday, Wednesday, Friday. That's enough, and that usually works perfectly. If you have a patient with cancer, infection, inflammation, heart failure, kidney failure, iron absorption will be poor because hepcidin levels will be high, iron absorption will be blocked, and you need to bypass the system. The easiest, quickest way is to give intravenous iron. There are some novel oral irons that can bypass this system, but they still need more time. So traditionally, if significant blood loss was anticipated during surgery, people gave transfusions as a routine. We don't do that anymore. We use these other techniques. And the cheapest technique of them all is to take a good history. Find out whether the patient has got a risk of bleeding, family history of bleeding, and look at the medications that she or he is on that could increase your risk of bleeding. This is a wonderful chart from Stanford University showing that many drugs, but look at the herbs and vitamins on the side here, can increase your risk of bleeding. And I've seen a life-threatening bleed in a patient who took omega-3 supplements and went for neurosurgery to remove a tumor. But look at the common things: cayenne, cumin, evening primrose oil that people take for premenstrual syndrome, garlic, ginger, ginseng, omega-3, St. John's wort, vitamin C and E. Many things here that are commonly used that can increase your bleeding risk. So in this patient, our lady that I spoke about, omega-3, St. John's wort, and the non-steroidal anti-inflammatories had to be stopped 10 days before surgery because all of those can increase bleeding risk. She had a relatively short time to surgery as it was semi-urgent, so she was given a single dose of IV iron 2 weeks before and increased the HB by almost 3. Surgery was performed with all these techniques, of which you can go and read in more detail in the article. Careful hemostasis, the anesthetist gave a gram of tranexamic acid, which is one of the things we do during and also after, and the hemoglobin increased nicely, or only decreased to 12 grams, and she didn't need a transfusion. So look at this paper. It gives you a lot of detail. I've just shown you one screen here of things that one can apply to patients like this. And in future, instead of just knee-jerking blood transfusion, let's really think about the impact of that. Think about what you would want to have if you were the patient undergoing the surgery. What would you prefer? I'm sure you would prefer prevention rather than transfusion. So thank you very much. I thought that was just something. I don't know if you have any questions on this particular case or some thoughts. See, we've got about 2 minutes left before we have to close.
So the remark was excellent. Thank you.
Thank you, Axel. I think if everybody has been stunned into silence by Axel's lovely talk, it remains for me just to thank again everybody. I think we can just say again, thank you, Axel, for the wonderful talk. Thank you, Echo University, New Mexico and India for the great technical support. We had absolutely no problems. There's going to be a feedback form that you can fill in. And just a reminder of next week's Echo session on pathology with Martin Hale and Bilal Bobat. It would be lovely to have you all there, and to remind you that the recording of today's session will be on the Gastro Foundation website. Axel, I hope you'll come back many times again in the future. It's great to have you. Thanks everybody for taking the time out of your busy afternoons to be here. We really, really appreciate it. Thank you, Karen Fenton, Chris Kassianidis from the Gastro Foundation for making this happen, for driving this process around Sub-Saharan Africa. Without you, I can assure everyone this would not be happening. And just an early advertisement, middle of the year, we are planning a patient blood management conference that will be both a combination of in-person and virtual. So speak to Karen Fenton. We are busy finalizing dates, but it will probably be early June. And Axel has already agreed to speak at that meeting again. Invite everybody you know, bring your children, your parents, your grandparents, everyone along. Everyone can benefit. Lovely to have had you. All the best and bye-bye.
Thank you so much. Bye-bye.